All right. Thank you again for everybody for joining us today. I would like to introduce our speaker today. Dr. Tamasi Sohi is an associate professor of neurology and physical medicine and rehabilitation at the University of Colorado Anschutz Medical Center. She graduated from medical school at the University Kansas School of Medicine and completed her residency training in physical medicine and rehabilitation at the University of Colorado, followed by a year of fellowship in neuromuscular medicine with the Department of Neurology at the University of Kansas. Dr. Sohi is a triple board certified in physical medicine, rehabilitation, neuromuscular medicine, and electrodiagnostic medicine. She has been a full-time faculty member at the Eastern Colorado VA Medical Center for almost 10 years and serving as the director of the interdisciplinary ALS clinic at the Rocky Mountain Regional VA Medical Center since 2018. Thank you, Dr. Sohi, and I'm going to go ahead and pass it over to you.
Thank you very much for the introduction.
All right. Can you hear me okay now?
Yes, we can. Thank you.
All right. Perfect. Okay. Thank you all for joining us today. First of all, I wanted to start by this slide. I don't have any conflict of interest to disclose. And as you know, I also work at a Veterans Administration hospital and wanted to make sure that these are my opinions and not the representative of the VA healthcare system. For this talk today, I wanted to go over some of the most common symptoms that we encounter with ALS. And in order to kind of understand them and better manage those symptoms, we'll talk a little bit about, very briefly, about how ALS affects the body, and then look at the most common symptoms that we can fit in through this 1 hour of presentation, and also look at the different styles of management. We can either talk about the pharmacological options and or the non-pharmacological managements that we have as choices, and then look at the pros and cons of different interventions. And then at the end, my hope is that we learn about things that are available out there, and then we find what we'll find out what would be the right choice for that individual for that specific presentation or symptom. So very briefly, we've learned about ALS since 1869. This is the neurologist who first described it, and then later on called it amyotrophic lateral sclerosis, which refers to the muscles losing their signal from the nerves that come from the brain and through the spinal cord. And then later on, we all learned, they called this Lou Gehrig's disease, especially in the US, after the baseball player Lou Gehrig was, affected by this disease in 1939. So very briefly, again, we know that it affects different body parts in different individuals. Sometimes it starts with muscles of swallowing and chewing and breathing. Sometimes it affects the muscles in the arm. And in some individuals, it can start in the legs and lower extremities. It's a progressive condition, and what sometimes we describe it as upper and lower motor neuron disorder. And I wanted to also describe that a little bit, in terms of what it means when we say lower motor neuron. That means that the nerves that start in the spinal cord and then come out of the spine and then go to the muscles are affected. And the presentation for those nerves being affected is usually muscle wasting, weakness, muscle twitches that we call them fasciculations, muscle cramps. And then also, it's one of the reasons that we do the EMG testing, that needle goes into different muscles and picks up these lower motor neuron findings that we call nerve damage to the muscle. For the upper motor neuron part of the involvement, it usually affects the part of the brain and cortex and the brain stem. The presentation usually is something that like people might develop some thinking and processing or behavioral issues because of that. Sometimes the mood gets affected because of the pseudobulbar effect, or there are some other presentations like they're even having some bladder dysfunction, swallowing and talking problems, and then some also have forced yawning, and then also a tendency to gag easy. As far as we know that based on different location, there's a different prevalence for the disease. In Europe and US, it's about 2.2 per 100,000. By definition, it is considered a rare disease because it's affecting less than 200,000 people in US. There's some areas in the world that have a lower or the lowest prevalence, like in East and South Asia, as far as we know. And it's again more common in white non-Hispanic males. And it's usually about 20% more common in males in the younger age, but then as the age progresses, then it becomes kind of equal actually between male and female. And then the map here also is kind of an overview of the increase in the number of cases of ALS worldwide, that we see that we are expecting to have almost like a 70% increase in number of cases until 2040. And this increase is more notable in countries that are more developing countries because of the growth in the age in the population. So switching gear to the topic of our talk today, this is the list of symptoms of ALS for today's talk. And I wanted to cover the only ones that are like bolded because of course, the time limitation. And also that feels that the ones that are not bolded, they probably will benefit from a much longer discussion and overview about how to manage those symptoms. If you wonder about all these numbers, this is next to the percentages, next to the symptoms. It's just based on a recent study that they showed, and they surveyed all the ALS patients that they had in that group, about 1,800 patients, about asking about their symptoms, how they felt like the symptoms were managed. Only 1/3 of patients reported back with the survey. And out of those 30%, the majority of them kind of reported again fatigue and muscle cramps and the stiffness to be the most bothersome, followed by some of the mood changes and all. So people with ALS and their loved ones may receive this erroneous message that ALS is untreatable. And this is an error that mostly roots in the misinterpretation of treatment as cure. And we do in medicine have a lot of diseases that we cannot cure. And treatment in the form of symptom management has long been a key role for the physicians and nurses and other healthcare providers, as again noted here by Hippocrates, more than 2,000 years ago, even before we knew about ALS. So one important disclaimer that I wanted to also mention here is the interventions that we are going to talk about today. The majority of the recommendations that we have are mostly based on the clinical experience and anecdotal recommendations and the knowledge that's gained and passed through clinician to another. Because we do have very few limited scientific studies for this very specific, symptoms. And there may be just less than 2 or 3 studies that we've had for like, drooling or pseudobulbar that were like scientific, that what we call these double-blinded placebo-controlled studies, that we have a control group and a treatment arm. And so I just want you to also be aware of that this is what we are, recommending here. This is what we know. This is what we think that works best. And then we also have some population-based studies that are gaining a little bit more popularity because Those are the studies that we look at the population, a big group of ALS patients, and they share some common traits. And then we try to gather data and extract data and make some conclusions based on that, on what would be a best management for this, to this group or this symptom. So they are good. They are a good source of getting data and information, but they also have some limitations since they're not like really controlling for a lot of variables. But starting with what we know about one of the main most important things that would be pivotal in the care of ALS and managing ALS is the multidisciplinary ALS clinic that, you know, we are making small, slow, but significant progress in finding hopefully a cure for ALS, but treating ALS through symptom management continues to be, again, the mainstay for ALS to improve quality of care. So in doing so, multidisciplinary approach to ALS care was established, like, you know, as we started to grow more knowledge about this condition and to improve mostly quality of care and survival. And these studies that I put in here are, you know, mostly population-based and observational studies that are done, most of them in Europe, that are showing that how involvement of patients and their caregivers with the multidisciplinary clinics can help with survival, quality of care, and improving quality of care and life. And, you know, as you see, like some of these are showing, you know, 9 months survival improvement, 10 months longer survival. And compared to some of the ALS medications that we have available, these are a lot more beneficial and significant. So this is a model of care that I hope that most people with ALS would benefit from, starting with the course of course, patient and family in the center for this to be a patient-oriented process, you know, and the big portion of the needs and cares to be provided, of course, by the different disciplines involved in the interdisciplinary clinic. But also important to note the role of other providers, you know, primary care manages all the other, you know, primary care medical issues like blood pressure, diabetes, involvement of, you know, in research and letting patients, you know, different research team how to navigate this, these possibilities. And also, you know, of course, with the ALSA and other volunteer community services that are very important in care and coordination and supplementing the care that patients need and their families need. So this is like a complex decision-making process. It's not just one person making one decision, and it's always dynamic. It changes based on the disease stage and the condition, and it always has to be patient oriented. So moving on to what we wanted to talk about with symptoms of ALS, we're going to start with the first symptom, that's fatigue. That was, you know, as a kind of an imprecise, but kind of a term, but in general kind of refers to low energy and loss of stamina, and often like having daytime sleepiness, like diminished alertness, and sometimes difficulty concentrating. It was not only the most frequently reported symptom in that survey I mentioned earlier, but also the least frequently treated one. And there are lots of things that can cause fatigue, and that's probably why it's maybe the least treated one, because so many things can affect and result in fatigue. Number one that we always think about is poor sleep quality, a variety of different reasons. Lack of mobility, when the body is not moving, the lack of release of endorphins and the muscles getting stiffer, that can cause more fatigue. Overexertion on the other side, like, trying to expect too much of the body part that's a little weak because of the muscle being weak, that can also cause fatigue. Mood changes can also result in fatigue, and then reversibly, again, fatigue can worsen the mood changes. And also sometimes when we have weakness in the muscles of breathing, the body can retain the carbon dioxide, and And that can also cause the sensation of fatigue, sleepiness, and lack of energy. Other things like being exposed to too hot or cold weather, those can cause extremes of, temperature can cause fatigue and tiredness. Alcohol, smoking, not having enough protein in diet. And then, not adjusting and modifying the home adequately enough to not needing to move too much to access different items that you need, the essential things that you need. It's too much work to get to the bathroom, too much work to grab something off the shelf. And then the other thing is also the medications. The big one that we sometimes forget and we need to always keep in mind is that a lot of medications that we use, they have the side effect as fatigue. And the study that they did for riluzole, about 30% of people who took the riluzole presented with fatigue as the number one side effect of the medication. The other medications that we also use for, other symptom managements can also present as, cause fatigue too. So we need to be aware of that. So how do we manage fatigue? So starting with the non-pharmacological management, first of all, we need to look at a few things that we can easily or hopefully start looking into fixing those. One is we need to look at the breathing. How is the breathing? Are we having issues with like a lot of yawning during the day? Are we feeling tired, waking up tired, with headaches? Did we have a sleep apnea before? So those are the things we need to kind of talk to a breathing doctor to make sure that those are evaluated. Also, looking at the quality of sleep. Again, this could be another hour of talk and how to improve sleep. But, one of the things, the culprits are always like, screen time or pain management or a lot of different things that can affect the sleep that we can look at. And then one of the biggest one is also the energy conservation techniques like that. I actually found some of these over on the ALS website that I find very helpful. These are some of the tips that, you want to, kind of consider, like make your environment very accessible, like, put your personal items, things that you need frequently close. You can use a power mobility instead of trying to push the chair with your leg or your arms. Don't take a lot of long, baths, hot baths, or, don't stay in the cold weather if you can. And then one of the biggest ones I always encourage is to always allow enough energy to enjoy at least one valued experience each day. That's what I really like. Because you kind of want to start your day by saying, okay, this is what I've planned for, to do. I really want to have energy to meet this person. I have this meeting with this person's coming over. And I really, really want to make sure I use my energy smart throughout the day. So by the end of the day, by 6 o'clock, when this person is coming, I want to make sure I have enough energy. So this is like kind of planning your whole day and like how much energy you're spending during the day as you go through. So moving on to medications, like what medications can be available. And modafinil or Provigil is the one that was I showed in the earlier slide. That was studied in the ALS population, showed some benefit. But these other medications, Ritalin, Adderall, Wellbutrin, they can also be used depending on your, other conditions that your provider is aware of, and they can kind of discuss the potential side effects and benefits for you. But the way they work for the most part is that they increase the feel-good, hormones and then the alertness hormones in your brain. So there are these dopamine, serotonin, and norepinephrine hormones that make us all kind of be a little bit perked up, and so that's how they usually work. But usually what you want to know about is that they might sometimes elevate your blood pressure and heart rate. So if you already have issues with that, that's kind of one big thing to keep in mind and mention to your doctor if they're not aware of that. And then also they some of these medications like Ritalin, Wellbutrin, they can also affect your appetite and weight. So they can reduce your weight and appetite. So if that's something that we don't want to lose ground on, then might not be the right choice for us. Moving on to the next symptom is another very common problem, common symptom is the muscle cramps. And we know that muscle cramps are, a sudden contraction of the muscle that's very painful in most people. But in reality, actually, they start in nerve. They generate their kind of signals that are kind of an overstimulated nerve that goes to the muscle and causes the muscle to contract. It's again very common. In a different study, it was reported in 90 to 95% of people, and it's the main source of pain in almost 2/3 of patients with ALS. And we don't have any like approved FDA drug. As I mentioned earlier, there's not like any controlled studies for cramps, but these are some of the options that we have as far as like trying without the medications. We always, start with hydration. Sometimes we avoid hydration because we don't want to be rushing in the bathroom or use the restroom frequently because we've got other limitations going on. Stretching is another one, especially if like we have calf stretches, calf muscle cramps. There are lots of different ways that we can stretch the muscle, range the joints. And those are things that you can certainly ask from your physical therapist on the team who kind of knows how your body is and kind of will give you some structures and instructions on how to do that. Gentle massage, of course, and using, swimming pools, especially swimming pools that are a little bit heated would be very helpful and for very low risk interventions. For medications, there are several groups of medications that we can use for muscle cramps. We have, magnesium. That's one of one of my first choices, especially in someone who has a little bit of constipation going on top of that, because it tends to make, give people a little bit of diarrhea, and it's very well tolerated. Then the other one is, of course, baclofen. That's very commonly used. The main side effect of baclofen is, of course, drowsiness and constipation. I put in the maximum dose here because you kind of want to, you might be on like some of that, but you're not, you don't know if you're taking enough or not, or if you could take enough, a little bit more. So you can discuss that with your doctor. I usually, again, start with something that I ask the person, like, when are your cramps worse? Usually it's worse at night. So we usually kind of use a higher dose at bedtime or before bedtime. So if that drowsiness is not a bad thing at bedtime, and then they, they benefit from a lower dose during the day if they need it. The thing with this medication is we want to make sure that you don't, like, if you feel like that you don't need it, you don't want to just like all of a sudden drop all the doses. You always want to talk to your doctor and then taper yourself off gradually, because your body gets a little bit used to it, and it might react, your muscles might react to it if you stop suddenly. The other medication that we can use is gabapentin. It's an anti-seizure medication that was not now used mostly for like nerve pain and muscle cramps. And again, we usually gradually titrate the medication. Again, I usually start with the nighttime dose because it can cause a little bit of drowsiness during the first few days when you're taking it. So it's best to take it at bedtime, and then you start adding the second and the third daily doses scheduled if you need to. The FDA has discouraged the use of quinine for cramps because of the safety concerns, because there were some reports around the platelets, the clotting factor, cells in the blood, and then the heart arrhythmias affecting the heart rhythm. with quinine. So they kind of said don't use it. So, but a lot of people can benefit actually from using tonic water because it has a little bit of a quinine in it. Mexalotine is another medication that I also use commonly in patients who don't have cardiac arrhythmias. If they do, then I have to kind of make sure the cardiologist is okay with it because it affects the heart rhythm. Usually I get an EKG just to make sure their heart is okay. And then we'll start the medication and gradually increase the frequency and the dosing. This is one of those medications, again, that causes fatigue and also causes bloating and diarrhea and upset stomachs. And that's one of the reasons that we don't usually go up as high as we want in the dose because of especially the upset stomach and the bloating side effect of it. Ranolazine is a new medication. Is not new for medicine. It used to be for like chest pain and cardiac world, but they've done some recent studies on muscle cramps for ALS, and again we found that is somewhat helpful, but again limited because of the GI side effects in some patients. And so we don't have that available yet for this purpose, but just kind of wanted to put it out there for you to know. Throat spasms, we call them laryngospasms, are also another presentation. It's not as common, but I thought I'd just mention it. There might be a few of people listening today might be having those issues. It's usually independent of the breathing function. That's just those muscles that just in the throat that they want to just generate cramps and are uncomfortable. And so the triggers could be the excess saliva and sometimes the smoking and acid reflux. Those are things that we know. And so usually we start with kind of trying to manage the acid reflux part of that, to avoid the acidic food, caffeine, lying down after big meals, or limiting the volumes of tube feeding if needed. And of course, tobacco and smoking. And then we use the medications that we can for, heartburn. And then we can also use the other medications I mentioned in previous slides for the muscle cramps, like baclofen and even quinine. Now moving on to another uncomfortable symptom, it's muscle spasms and spasticity. That's it's kind of like with cramps come and go, and then muscle spasms and spasticity is something that's kind of like there and stays. And sometimes it gets a little bit worse and sometimes it gets a little bit better, but it's always there. And it feels like, again, stiffness in the muscle, and it's a little different with the stiffness in the joint, of course. The treatment is, non-pharmacologically, is pretty close to what we do for muscle cramps with, muscle stretches, range of motion exercises, and all that. And in different people, it can actually present differently. In some people, they don't have any muscle spasms, and in some people, they have it diffusely all over the body. And so kind of have to be, kind of decided which way we need to be, managing this depending on the severity. These are the examples of like how people, or how different limbs with spasticity can look and can cause problems. Like in this case here, the inner thigh muscles are really tight, so bringing the knees in, so it makes it really difficult for hygiene and dressing. This sometimes in the middle makes it hard for positioning in the bed. The one next to it with the knee extended and straight, that makes it a lot hard for people to like sit in a wheelchair and or get in a car. And then the ones in the, on the bottom are the ones that usually get a little bit uncomfortable, especially at rest, causing a lot of cramps and discomfort. Or if, someone wants to weight bear, might become difficult with like leg shaking and sudden movements there. So these are the medications that, we use when muscle spasms are more diffuse and affect kind of like an entire arm or leg. We kind of try to do kind of like a systemic approach. So we use baclofen. That, again, as I said, the main side effect could be, again, drowsiness, sometimes fatigue. And you kind of gradually start the dose and divide it in different doses as needed. Tizanidine is another one. Dantrolene also is a very good muscle relaxer, but it requires monitoring of liver function. And so because of that, there are very, very rare cases when liver reacts really poorly and gets affected because of this medication. So a lot of providers are hesitant to start. I practically, in my practice, find it relatively safe to start with a smaller dose and then gradually increase it while monitoring the tests and liver enzymes in that person. Benzodiazepines are also used for muscle spasms, but again, those are the ones that can also suppress the breathing center in our brain and then can cause more fatigue. So we kind of want to use them pretty much on this list. I would go from top to bottom, like with my preferences, start with baclofen and tizanidine or dantrolene, and then the benzos are the ones that I use least frequently. And then in cases when muscle spasms are focal and localized to just a few muscles, like only in the calf muscle or in the, kind of a wrist or forearm, then we use this botulinum toxin injection. A lot of us kind of know that as Botox, but Botox is just one brand out of many that we have available. Now we have Xeomin and Dysport. So those are things that can be done. The medication gets injected into the muscle, so the muscle relaxes. And of course, it's not going to be effective right away. It takes about 5 days for it to work, and it lasts about 2.5 months. And then we might need to repeat the injections again. We, of course, have a maximum amount that we can use. We can't just use any amount that we want to. And we got to always be careful about the systemic effect of it. We don't want this to be going anywhere else in the muscles that are not affected. And so we don't want to cause any weakness. If we go higher on the dose, then it's going to be more likely for us to have this problem. And then this one is the intrathecal baclofen pump that, in my practice of, 10 years being involved with the ALS patient care, I have not had a single patient using this. This is more of a theoretical possibility, at least as far as I know, because it's an invasive procedure that requires hospitalization to test for this. And baclofen is something that goes into the spinal cord. There is this pump that they put it. And it's just a little bit on the invasive side of things that not very commonly used. And then marijuana is also, has also shown to be helpful with muscle spasms. And of course, our knowledge is limited due to its, regulatory status. And but at the VA, I cannot recommend that, of course, to anybody. But if someone is asking about it, then I always recommend responsible use in a safe environment, controlled environment, with purchasing from a vendor that the dosage is reliable, and increase with small increments, and kind of make sure, again, you are in an environment that's supported. If something comes up and happens, you have help. Because they did one small study, and then it did show some help with reducing the spasticity and muscle spasms in ALS patients. The same thing with topical CBDs. I would say that that can also be safely tried, especially again for areas that we feel like that is just a calf muscle, or just this area that's really bothersome. So one thing to just remember is every time we are managing the muscle spasms, because muscle spasms are kind of giving us tone and kind of holding things together, we might unmask some weakness, and then the mobility might change a little bit, and it might, change for, making things a little bit more difficult. So always kind of, be in communication with the doctor about what the plan is, and, maybe a follow-up. I always recommend a follow-up with a physical therapist to make sure that we are seeing the benefit that we wanted, and we are not like, sacrificing a stability for just managing the tone right there. Moving on to the next very common symptom, pain, that in ALS could be related to several things, at least three main things. One is simply just because of lack of mobility and poor positioning. Like in this picture, these are all the possible areas that could hurt, either because of the positioning or because of the pressure that, is that person is just sitting on. And some lack of mobility, like sometimes the shoulder just gets frozen because we were not able to move that. It could be because of the arthritis, just like an arthritis that anybody can have over time. It can be arthritis in the spine, we call that degenerative disease, or other joints like hip and shoulder. And then also we can have pain due to neuropathy that usually again caused by other things other than ALS, but it's another pain by itself to deal with. So shoulder pain is a very common one with ALS, and can again be caused by arthritis, rotator cuff muscles, and frozen shoulder. In general, the shoulder is not a very stable joint, and it relies on all the other muscles that we call them the rotator cuff muscles to hold it together. And so because of the ALS, these muscles are weakened, then the stability of the shoulder is not there. So every time the shoulder is moving, the arm is moving, then this big kind of instability can generate pain and discomfort. And then sometimes because of that, we tend to like hold the arm in one place and not move it. And we end up with a condition that's called frozen shoulder, and that by itself can also be generating pain. So things we can do is, first of all, if we are seeing significant amount of muscle loss around the shoulder area, and we can certainly make sure that we, protect the shoulder by, propping the arm. Don't let it hang with gravity. Protect it. I don't like, and I'm not a big fan of the shoulder slings, but again, in very severe cases when we have lost a lot of muscle there and there is not a lot of range of motion and there is discomfort with movement, we can use it, but I try to avoid it as much as possible. And then, of course, doing range of motion exercises, this is one of them, but there is a lot of different kinds that you can talk to your physical therapist about, the ones that are safe and most appropriate for your body. And then, of course, these are the pain medications, starting with like Tylenol and ibuprofen, and then even narcotics. But, with all these, we need to make sure we take them at the right time and right dosage. And especially with narcotics, they can have a lot of side effects. And we kind of want to make sure we try to avoid them as much as possible. Another thing that I commonly do with my patients with ALS is that, again, doing shoulder injections. You can do these local cortisone shot injections. That's a combination of cortisone and numbing medicine that goes in with one shot. This is showing that there is an ultrasound machine that's guiding the doctor to put the needle in an accurate place to increase the benefit and minimize the risk of the injection. It helps a lot with the pain and discomfort and inflammation in the shoulder. It's not going to fix the muscle weakness. It doesn't fix the arthritis, but it certainly helps a lot with reducing the pain. And unfortunately, of course, it wears off after 2-3 months, and we repeat those again as needed. You want to keep these injections over over a year to 3 or 4 per year, just to make sure the side effects don't get too much, because in people, especially who have like diabetes, it can elevate their blood sugar over time. Moving on to the neck pain, is this is like what causes neck pain in all of us, right? Like kind of sitting with the head forward, tilted position, head forward position with the neck muscles kind of stretched. Sometimes this happens just because we have muscle weakness in our neck, and the muscles in the back of our neck are not strong enough to hold the head up. And so we don't want to do that, but we also want to like use tools like this headmaster brace that lifts the chin up. It doesn't cause too much limitation, but it also protects and gives support to the neck muscles. Also make sure you have a good headrest in your chair, that when you get tired, you can lean back and don't exhaust those muscles in your neck. And then leaning back, if you're using a power chair that has the tilt back feature, this would be a good way to kind of reduce the pressure of different areas, including those muscles in the neck that are supposed to hold your head up. There are other locations that can also hurt, like the places where your knees are touching, the places where your hip is touching the mattress or the bed. These are all these bony areas where we have like these sacs of fluid that are supposed to be helping with muscles moving over the bone, but then they can get irritated and inflamed. And this is showing a very common injection again that I do. It's a greater trochanter injection. It's another bursa that gets really inflamed on this side, and then it becomes very painful, especially if this person wants to lie down on that side. And again, it helps for 2-3 months with pain and irritation over time. Nerve pain is another big one that we also deal with. It again usually is caused by other things, not ALS, like diabetes, vitamin B12 deficiency, too much alcohol, or too much vitamin B6, and many other factors, like even if you had back injuries, back surgeries, things like that. One thing to know is like always mention to your doctor if it's old versus new, because if it's an old nerve pain, we don't need to investigate the cause as much. We just treat the symptom. But if it's a new nerve pain, we kind of need to investigate the cause and see which one of those causes I mentioned, are at play. And they're usually worse at night, and they feel differently in different people. Like some people feel it as burning and pins and needles, and some people feel it like as cold and hot and all that. So it's always your choice to decide how and if you want to treat that. Is it bad enough for you to be on another medication for it or not? And again, we talked about gabapentin and pregabalin. These are the maximum doses. Again, I put them in because a lot of times what happens is that we start with a small dose and then we don't increase it, and we kind of give up on the medication and say, oh, that didn't work. In reality is that we did not give the medication enough chance and high enough dose to work in our body. So always talk to your doctor, provide feedback. Is like, okay, it didn't work yet, and maybe we need to increase the dose. And then safely, as your kidney function allows, you can go ahead and increase the dose with your doctor. It doesn't affect your kidney. I want to emphasize, it's just these medications are cleared through your kidney. So how much your body is going to maintain and keep it in depends on how fast your kidneys are clearing it. So that's why your doctor needs to look at your kidney function and increase your dose. The TCA, or tricyclic antidepressants, and you probably heard of Elavil, nortriptyline. Those are the ones that are also used for nerve pain, that have a lot of side effects. They're not my first choice because they're, you have to watch for heart condition and a lot of anticholinergic effects. What that means is that it's going to cause a lot of dry mouth, dizziness, constipation, and even urinary retention. And then SNRIs that are actually my preferred choices, because they're the one that have a lower side effect profile, and then also work with the feel-good hormones in the body. So they help with some of the fatigue side effects and also help with the nerve pain and mood. So always gentle range of motion. Ask your therapist about the exercises you can do. Be aware of the positioning and other options like massage and acupuncture. We talked about how ALS can be, associated, and even, depression, anxiety can be more common in ALS because of a lot of different things. And the management and approach to that is multifaceted, is, a combination of medications, managing the symptoms, therapy and counseling, and also sometimes visiting with the palliative specialist with your family to reorient to your goals of life and establish what matters to you for yourself and your loved ones. Pseudobulbar effect is another symptom that is also important to mention here. Is a kind of one of the earlier signs of ALS in some patients that pretty much shows up as laughing or crying out of proportion to what you're feeling. So it's like an emotional dysregulation that's could be stressful to that person, because they are aware in there that they are laughing inappropriately, but they can't control that. And it can also be a little bit confusing to communicate with your caregiver or your loved ones. And it's not only that happens in ALS, we see it in other conditions. So the first thing is usually to be aware of that, I usually try to educate the group of people involved, like the patient and the caregiver, just to say this is a part of the disease process. And we don't always need to treat it unless it's becoming disruptive, it becomes too stressful for the person, or it disrupts the communication and care. Nudexta is the medication that's FDA approved for this specific condition. They did this study, and it's a combination of quinidine and dextromethorphan. That's a cough medicine, actually, that can be used. And again, you need to kind of usually get an EKG, baseline EKG, to make sure the heart is okay, because it can affect the conduction of the heart a little bit. It also showed that there are some benefits in like swallowing and saliva management. So if I have a person who is dealing with those issues, then that would be a kind of a drug of choice for me to try, instead of using, the TSAs or SNRIs that I mentioned earlier. And so this is the next one, the excess saliva that some deal with, because of mostly the muscles of the swallowing and controlling the mouth are not strong, so the closure is not there adequately, or the swallowing doesn't happen as frequently and as often as effectively. So, and it can be actually worse with things like acid reflux, things you eat, or, put in through the tube feeding, and it can be worse with constipation as well. So it starts with simple solutions. A portable suction device sometimes can do it if we have enough hand function to handle that. A small washcloth, and then the medications that we use are all like, I mark them as an anticholinergic. Again, remember, those anticholinergic ones are the ones that are causing dry mouth, dry eyes, constipation, dizziness, urinary retention. And so that dry mouth part of it is helpful here, but the other side effects we need to be aware of. So I usually start with this atropine eye drops that are like going under the tongue and not the eye, and then go down this list of glycopyrrolate, that's a medication by mouth, and the scopolamine patch that goes right on the neck behind the ear. The radiation of salivary glands is, again, another one that they can do to kind of like radiate and dry out the salivary glands, but it can have some side effects like sore throat and nausea, and I have not recommended that to any of my patients. But I do, very common is the botulinum toxin injections that I use ultrasound guidance to do this, because it's very important to make sure I'm not putting that toxin in the muscle, because these are the glands right here and these are the muscles. So I use the ultrasound to make sure that the toxin goes into the gland and it dries out the production of the saliva. And it lasts for about a good 2.5 to 3 months, and they don't need to use the medications. But when the Botox starts wearing off, then kind of have to start going back on the medication until they come and see me again. Sometimes if we use it too often, it can cause thickness in the secretion. So we kind of, start, to kind of taper up down a little bit and increase the inner walls, and that kind of gets better over time. Constipation is another one that is a big one that happens because of a lot of factors: lack of mobility, lack of fiber, hydration, and all the medications we talked about. As I said, we hesitate to hydrate because we don't want to go to bathroom. And so using a urinal, using a condom catheter that is not an inserted catheter can be helpful, and it kind of goes right under the cover and your clothing. Use all different options, including probiotics, and talk to your doctor about all these different medications that you can use stepwise and gradually. Lymphedema is another big one that happens a lot of times just because the limb is weak. The muscles are not pumping the fluid against the gravity, and it's sitting and pulling, with the fluid going down with the gravity in the arm or leg. So we want to make sure, if it's all of a sudden something that happens and wasn't there yesterday, we want to make sure we mention it, because it could be, related to something related to the heart or blood clots. But if it's something that we see at the end of the day, it's like, okay, when we get out of bed, but it gets worse by the end of the day, that's probably the gravity pull. So we usually don't use diuretics because it can cause more muscle cramps, but compression stocking, keeping the limb elevated, and again, making sure you tilt back to keep the legs up a little bit as much as you can. If you're using wheelchair, that would be great. So the bottom line here is, there was a lot of things that we talked about, and I shared with you my anecdotal experience and knowledge about what's best and what I use. But I want you to know you have options. There are lots of different things that you can try, but you are the one in charge to decide which one of my symptoms are bad enough that I want to try a medication or a non-medication path for. And is it worth the side effect? Yeah, that's a big question to know. And sometimes you have to try to know if it's worth the side effect or not. And then always ask your doctor, like, can we combine these medications? Like, can I use a medication for pain and pseudobulbar? Can I use a medication for both pain and depression? So that way we don't use two different medications for two different symptoms. We can use maybe one medication for two different presentations. So I'm sorry, I kind of rushed a little bit. I wanted to leave some room for questions. That's all.
Well, Dr. Sohi, thank you so much. We do have some questions that are coming into the chat, and I'm happy to be able to read them out, because you have been talking for quite a bit and you might just need a sip of water. If you don't mind, we can let's unshare. Stop sharing, and that way we'll just kind of have our Hollywood squares here, and we can go through the questions. So the first question that we had from Mark is that, has frozen shoulder been seen as pre-symptomatic indicator of people with ALS?
I'm sorry, did I unshare already?
Yes, you did. We're all set.
I'm so sorry. Can you repeat the question?
Yes. Has frozen shoulder been seen as a pre-symptomatic indicator of ALS?
That's a hard one. So sometimes, yes. So what is the cause of frozen shoulder? If frozen shoulder was painless, weakness of the shoulder, and then we all of a sudden seeing that this shoulder is lacking any muscles and then also not moving, yes, it can be. There are people who present with just lack of mobility in the shoulder and then the muscle wasting in that area. It's not very common and it's not very classic, because the types of ALS that usually present in the shoulder girdle area are not very common.
Okay, thank you. From Sherry, my husband's eyes will start to burn all of a sudden. Are burning eyes common in ALS? Rubbing them makes it go away and it doesn't last very long. And then we had somebody else who said this happens to my husband too. He constantly says it feels like something's in them, but can never see anything, or that they're burning.
So I honestly have not heard of this, encountered this personally, but the main thing I always think about if someone is reporting some burning sensation in the eye is dryness. A lot of times because of the muscles getting weaker in the eye, like closing the eye can be a little harder. And so that the eye can get a little dry. And so sometimes maybe putting like just artificial teardrops can help with the dryness. And then hopefully that would help alleviate the burning sensation in the eye. Yeah.
So this is my personal just follow-up question, and maybe I'm opening a can of worms, but if you're taking a medication for, excessive saliva that we talked about that can give you constipation and dry out the body, do those medications maybe affect the moisture in your eyes as well?
Yes, they can. Yes, they can. Because as I said, they are called anticholinergic. That's the word to remember. Anticholinergic medications are the ones that cause dizziness. Like when you stand up, you get dizzy. They cause dry mouth, dry eyes. And that's why we use that dry mouth side effect to our advantage for drooling. They can cause urinary retention. Like if you have like bladder or prostate issues, you already had that problem, this is going to develop on that. So always to kind of make sure you check on, like with your doctor, what group is that? Like, is it anticholinergic or not?
And if you have some, symptom, talk to your doctor, talk to your team, and be aware, say, well, I'm on this medicine, and just problem solve with them how to be able to take care of the problems without creating, maybe, like you said, a side effect that may be more uncomfortable.
Exactly. Yes.
Okay, so we have from Terry, will the botulism medication for saliva cause the whole mouth to be drier? My sister has dry mouth from her ventilator.
Yes. So yes, that's another thing. The mouth dry from the ventilator, those are things that, again, that could be a good talk, like how to manage and deal with all these breathing machine and breathing devices. And dry mouth is one of the very common symptoms of using the ventilator. And we sometimes try to be creative with that respiratory therapist, different masks and different models. And then also a humidifier added to that can help. Sometimes if you don't need to use the oxygen, you probably don't need to. Just make sure you ask for, like, do I need to have oxygen? Because that's another factor that can cause dryness if it's added. So, but yes, botulinum toxin, what it does, it actually prevents the production of saliva, right? So I always start with a small dose, and then, like, based on the response, I say, okay, we just want the amount of saliva to be there, but not too much, right? And even if we target and inject those 4 glands, we are still going to have about 20 to 30% production by the other sources in our mouth, because there is saliva being produced, in other places other than these 4 glands. So as long as we are not using a very high dose, I haven't had anybody having dry mouth right at the beginning with the injections, unless, again, it comes with like adding other medications and the breathing devices or increasing the dose.
Well, thank you. And we did have one question that apparently came up as you were answering it. And so just to reaffirm, the physiological cause of excessive salivation is related to the muscle weakness, correct?
Yes, yes. So there is nothing wrong with the saliva production. It's the matter of how we are managing the saliva, because the throat muscles and the lip muscles are not strong. So the mouth closure is not strong. And then the throat muscles are not clearing the saliva as frequently and as effectively as they should. So this kind of stays in the mouth, and then if the mouth is open, then it kind of drools out, and kind of sticks out a little bit and gets uncomfortable for a lot of people.
All right. Well, I want to thank you, Dr. Sohi, very much for a very, very informative presentation, and we can talk offline, but I'm really hoping that we can have a copy of your slides just to be able to share with people who were furiously trying to write things down.
Of course.
And then if additional questions do come through, I think the one thing that we learned, especially from the beginning of your presentation, is you need to talk to your ALS clinic team and talk to your physicians. And if you don't attend an ALS clinic, be sure that your healthcare professionals, that you are sharing all of this information with them. And that goes for also if you're using, you know, the medical marijuana. People always forget about medications that are over the counter or not prescribed, but there can be a lot of different interactions. So I think communication with your team is the biggest thing. So thank you
Absolutely.
very much, Dr. Sohi, for your time and your busy schedule and all of your expertise here. And I want to say thank you for everybody attending and joining us today. And so have a pleasant weekend. And if there's anything you need or questions you have, remember, you are not alone, and that we here at the chapter are here for you. All right, everybody take care.
Thank you.
And Len, we'll follow up with you on Hoyer slings, okay? Have a 9" by 13, okay. Oh, I'm talking out loud in my head. All right. So glad that everybody was able to join us. And I'm just going to make a note to follow up with you, Len, okay? And it may be Jared that follows up with you. And oh, you can come off mute.
Yeah, he's out of town right now.
Jared?
Jared, yeah. You know what? He did give me Michael's number for the.
Oh yes, Michael, for the other nonprofit that has equipment. So, well,
Yes.
we'll be sure to follow up with you. And it was good to see you. I don't know if you remember, I met you probably a year, almost 2 years, no, almost a year ago at the clinic in June.
Very good. Yeah, it's been a year.
Yep. All right.
Okay.
You take care.
Okay, thank you. We got a sling that's got an oval hole 9" by 13", and if I don't
Too
position
large.
her, just my wife's just right, Jan, that she gets stuck in there. And at one point, I had to cut the sling to get her out of it. It was kind of a lesser of the two evils of trying to fight her and pull her out of it. Do they make a smaller sling?
They do make smaller ones, but they also make a different design, something called the split leg that might fit her better. So I will send you some information on that.
Okay, hey, thank you very much.
Yeah, you're definitely welcome, Len.
And Doc, thank you. Bye-bye now.
Bye-bye. All right, and to help everybody else out, sometimes it's hard to be able to sign off. Dr. Sohi, I'm going to go ahead and sign off, but if you want to chat afterwards, we can. Otherwise, I will see you at the gala.
Yes, we'll see you then. Have a good one. Thanks for the opportunity. Appreciate it.
All right, thank you. All right, everybody else, I am going to go ahead and close the meeting and make that easy for everyone.